Good evening, everyone. Welcome to the second Shared Maternity Care Collaborative Workshop for this year. I'd like to commence by acknowledging, on behalf of the Royal Women's Hospital, Mercy Health, Northern Health, Western Health and Northwestern Primary Health Network, that wherever we are, we're meeting on the lands of the traditional custodians of the land. Where I am, it's the Wurundjeri people of the Kulin Nation. And I'd like to pay our respects to elders past, present and emerging, as well as to any Aboriginal and Torres Strait Islander people in the session with us today. So just some housekeeping. All attendees are muted. Please ask questions via the Q&A box only, and I'll generally collate that into a thematic analysis after the two presentations. The session's being recorded, and I'll ask those questions anonymously to protect your privacy. Please ensure that you've joined the session today using the same name as your event registration. In that way, you'll actually get a CPD certificate from the PHN. If you haven't, via the chat box, please just to Northwestern PHN Education identify yourself so that they can cross-reference that in order to provide a certificate, and everyone's given you a little wave there to remind you. I'd like to commence the session by just acknowledging the help that we received from Yvonne at Northwestern Primary Health Network, and also the enormous work that Emily Wilson, who works with me, has done to get the session organised. So on behalf of the collaborative, welcome and thank you for your provision of shared maternity care and prenatal and postnatal care to the many women that you care for. So at Mercy Health, the two people that run the unit are Sharon Chisholm, who's here today, Sharon give a wave, and Caitlin Shaw, who couldn't make it this evening. From Northern Health, we have the consultant obstetrician and gynecologist, Arzu Khalid, Arzu give a wave, and Richard Sear, who couldn't make it today. On behalf of Western Health, we have Dr. Jo Silva, who was online. She's online somewhere, but you can't see her face, and also Sky Spencer. And on behalf of the Royal Women's Hospital, it's Emily Lawson, who was here as well, but she's online, and myself. So I have the pleasure of knowing many of you online. I'm a GP. I run the GP liaison office and also provide a clinical oversight to shared maternity care at the Women's. I have a number of other roles, both for other organisations and advisory positions, largely for the federal government. So this session will be going through gestational diabetes and thyroid disease in pregnancy, haematological conditions in pregnancy, and we'll do some updates and very topical issues in our provision of maternity care for women. So I'd like to start off introducing Dr. Jessica Deitch, who's an endocrinologist at Western Health and Alfred Health, and a PhD candidate with the University of Melbourne. Good luck with that, along with all your other work, Jessica. She graduated from Monash University, yay Monash, in 2015 and completed her endocrinology training through the Alfred and Western Health, and was awarded her specialisation in 2023. Jessica has an interest in a broad range of areas within endocrinology and a particular interest in obstetric endocrinology, and her PhD current research relates to the screening and diagnosis of gestational diabetes. So thank you for being with us and presenting today, Jessica. Over to you.
Great. Thanks
I'll
so
stop
much.
sharing. Do you want me to stop sharing?
Yeah, perfect. Then I'll be able to control the slides. Seconds. I'll just share my screen. Perfect. Hopefully that should be up for everyone. Yes.
Perfect. We can see that.
Great. Perfect. Thank you for the introduction. So I'm Jessica Deitch, and endocrinologists predominantly do my obs endo work at Western, as clearly the Alfred does not tend to manage pregnant women. They go elsewhere. So today I'm going to do a cover of some of the updates in gestational diabetes and thyroid disease in pregnancy. The main focus from GDM will be currently on some screening guidelines and where things are sitting at the moment. And there's probably going to be some movement again in this space in the next probably 18 months to 2 years. And then in thyroid disease in pregnancy, we're going to focus potentially mainly on hypothyroidism this evening, but also just touch on some other interesting topics within this area. So as we all know, gestational diabetes is defined as abnormal glucose intolerance, which is first with onset during pregnancy, not in keeping with thresholds for overt diabetes mellitus. We're all aware that it's associated with significant adverse perinatal adverse maternal outcomes, as well as future risk of maternal type 2 diabetes and cardiometabolic disease in the offspring. This is just from this particular, so I should just say for further resources, this particular review by Ariane Sweeting is a Sydney-based endocrinologist. This has been a fantastic gestational diabetes review just published 2 years ago and includes a number of Australian authors and is quite a nice summary of this topic. They had quite a nice slide, just a different way of highlighting different perinatal complications in terms of that maternal insulin resistance leading to increasing maternal circulating glucose and free fatty acids, and how that translates into a number of the neonatal adverse outcomes that we monitor for. So we know that GDM prevalence is increasing, and there's a huge host of reasons for that. The quoted Australian GDM prevalence for 2021 and 2022 is 17.9%. So that's just from the Australian Institute of Health and Welfare data. We know there are changes to epidemiological factors, particularly increasing maternal age, BMI, sedentary lifestyles, and also the ever changing background risk in terms of different ethnicities with migration. The GDM screening criteria change did come into place in 2015, and there was 2014 to 2016 amongst various centres throughout Australia. We know that that was predicted to cause an increase in GDM prevalence, but clearly we're seeing ongoing increase in GDM prevalence that isn't all attributed to that screening criteria change at that point in time. And just to show locally, so this is some local data from Western, just to really show the differences in GDM prevalence based on the population that you're looking at. So our 2020 prevalence was nearly 24%. So nearly 1 in 4 women who deliver through Western have a pregnancy affected by gestational diabetes. Our particular population that we manage out west, we have nearly 50% of our women are born overseas. There's a large population from high risk ethnic backgrounds, in particularly Southeast Asian and South Asian. So very different to if we were looking at other areas in Melbourne where the prevalence may be a lot less. So optimal screening clearly remains controversial both in Australia as well as internationally, and I think that's where a lot of the confusion and also a lot of the discrepancies between even health networks amongst Victoria in terms of both GDM screening as well as treatment targets as well. And certainly there's been a bit of a shift over the last 10 years where previously the diagnostic criteria focused on the risk of future maternal diabetes, and now we're really looking towards identifying perinatal risk and identifying GDM to reduce that as a main outcome in the short term. This is just showing a bit of a table to really show the number of different screening modalities throughout the world. Where Australia fits in is in the top left under the IAD-PSG, or International Association of Diabetes and Pregnancy Study Groups, which is an international group that had consensus-based guidelines sort of about 10 years ago, and the Australasian Diabetes and Pregnancy Society falls in line with that. We can see going down to that second row, the ADA, and then which is American guidelines, and even thirdly down, which is ACOG, which is the American Obstetrics Guidelines, have vastly different criteria. So it's a very muddy area, and just sort of showing locally some of the changes to us here. So the 2014 IAD-PSG guidelines in the middle of this slide, with using a single 2-hour 75-gram oral glucose tolerance test for all pregnant women, which is endorsed by ADIPS, is very different to what was the previous screening, which was looking at the non-fasting glucose challenge test, then followed by a 2-hour glucose tolerance test. So I just wanted to briefly run through some of the evidence to, I guess, to suggest why we are where we're up to at the moment with current screening. So probably the biggest and most important trial in GDM research at the moment is the Hypoglycemia and Adverse Pregnancy Outcome Study, or HARPO. And this was a large international multi-centre prospective observational study, and it was published in 2008. Importantly, this was a large group of women that were untreated for hypoglycemia that was less severe than overt diabetes mellitus. So this was observational data in untreated women for what we would treat now as GDM. And interestingly, just I guess the most important slide from this particular publication it's really this continuous association between this oral glucose tolerance test that was done at 24 to 28 weeks. We see a continuous relationship between fasting 1 and 2 hour glucose levels and the particular adverse outcomes that were being assessed. So the challenge at the end of the day is, where do we draw the line to say what is gestational diabetes that's going to cause potential adverse perinatal outcomes and what is normal? And it's very challenging when we're looking at a continuous relationship because there isn't a specific threshold. And then two other trials that were around that particular time were some RCT evidence-based trials. So this was an Australian study published in 2005, and this was showing that there was significant benefit if we did treat women with this milder form of hypoglycemia during pregnancy. So we can see in this case it was, although they did have we had sort of an OGTT with a, sorry, apologies. So these were women who had one or more risk factors for GDM on the selective screening at the time, which was the glucose challenge test. They'd also gone on to have an oral glucose tolerance test, and they were randomized to routine care, which these women would not be treated as diabetes, or an intervention group where they were treated with a target fasting down to 5.5 and a 2 hour less than 7. And again, there was significant benefit shown to treat this milder form of hypoglycemia. And then similarly, the Maternal Fetal Medicine Units Network trial, again, another trial that was showing there was evidence for women who were treated for this milder hypoglycemia or GDM. So again, in this particular trial, women were treated to a fasting of less than 5.3 and a 2 hour postprandial of less than 6.7. And there were significantly lower rates of LGA, macrosomia, shoulder dystocia, preeclampsia, gestational hypertension. So where that, in terms of the guideline changes in 2014 and what we're using at the moment, this has importantly been consensus-based and a consensus decision. So certainly looking at the HARPO data, the decision was made to draw the line, if you like, on those graphs at the odds of the primary outcome occurring being 1.75 times the odds of these outcomes occurring at the mean glucose levels of the HARPO cohort. So that's where our current OGTT values come from. And the couple of RCTs I've just briefly summarised as well also gave further evidence that we should be treating women. So this is what we're left with at the moment and what's in place currently. There are some slight variations internationally, and New Zealand actually use higher criteria than this and now have just been bringing in the criteria we're using at the moment. But this is certainly probably the most common criteria that's being used. In terms of early screening, so this is also a bit variably nationally. So the ADIP Society have recommended that if patients have 1 high risk factor or 2 moderate risk factors, they should be having early screening, and this is with an oral glucose tolerance test. The timing of that oral glucose tolerance test is quite controversial, and really at this stage, this is still quite a muddy area, if you like, in terms of when this screening initially was to try and make sure we've picked up type 2 values that would be in keeping with diabetes in pregnancy or type 2 diabetes early in pregnancy. But the question remains is if we have OGTT values in keeping with gestational diabetes, what's the significance of that? And certainly the significance of early GDM really has been unclear, and the risks and benefits of treating or not treating have also been unclear. There's been quite a bit of observational data showing that there's probably some evidence of treatment for early GDM as untreated. There's a couple of points there, but there's some evidence of some accelerated fetal growth before that 24 to 28 week standard OGTT. And potentially a linear relationship between fasting glucose levels in early pregnancy and adverse pregnancy outcomes later in pregnancy. So the toboggan trial has been quite a... Oh, sorry.
Oh, no, that's okay. One of the things that frequently comes up is the timing, as you've said, of the early GTT. And certainly, I work at women's and it's confusing for me, let alone people that don't, because often GPs, if somebody's at risk, actually organise that with their initial bloods at sort of 6 to 8 weeks. But frequently, if that's mildly elevated and would normally be in the GDM range, usually at women's, we say actually just repeated at about 16 weeks or so. And so we're dissuading people from doing it at that very early stage. Could you please comment on that?
Yeah, it's a great comment. Certainly at Western, that's what we do with our local practice as well. And it's often looking at probably that 13-week mark and looking at after then. It's quite challenging because when we're seeing women with their first, they may be seeing it, a GP as early as, 5-6 weeks pregnant. Certainly a fasting plasma glucose or an HbA1c that's in keeping with type 2 diabetes would be very concerning in terms of that being a new diagnosis in pregnancy that needs to be acted on urgently. The question is, what do we do about particularly a fasting glucose that doesn't meet that level of 7 and is more mild? So I must say our local guidelines are very similar to the women's in that an early OGTT at 4 to 6 weeks, if it's not in keeping with type 2 diabetes or overt diabetes in pregnancy, we end up repeating it after about 12 or 13 weeks.
And you're talking about diabetes in pregnancy is essentially that sort of non-diabetic parameters of pregnancy as opposed to the lower pregnancy ones.
Yeah,
Thank you.
exactly. So where things muddy the water, and this is certainly not at entering guidelines right at the moment, has been the toboggan trial, which I'm just about to talk about now. Before this particular trial, and this particular trial that's happened over the last couple of years hasn't made its way into changing guidelines, but is likely to in the next 1 to 2, probably in the next 2 years or so. Certainly at the moment, we'd say that very early screening of fasting plasma glucose and an HbA1c is potentially going to be practice changing if it's in keeping with those classic type 2 diabetes values. Milder hypoglycemia, there's a big question mark. And at this stage, we are also saying that the oral glucose tolerance test for early GDM screening would be doing later into that 13 to 14 week range.
With the idea that that HbA1c or elevated level actually indicates diabetes prior to the woman getting pregnant rather than diabetes in pregnancy. Yeah, thank you very much.
The HbA1, and just while because it's probably a topical point. So HbA1c testing during pregnancy can be quite inaccurate. Particularly later in pregnancy, there's obviously lots of influences with the hemoglobin count itself, iron levels, and other factors that mean the HbA1c may be less accurate. With gestational diabetes, we're expecting that the glucose intolerance and insulin, the glucose intolerance and the mild hypoglycemia should be something that occurs into the end of second trimester. So if we do an HbA1c at standard testing time at 24 to 28 weeks, well then looking at 3 months worth of glucose levels won't be picking anything up that's reflecting what's happening now, which is unfortunately why we're having women do an OGTT, which is not a particularly pleasant investigation, but why we're doing it at that point in time to get the glucose values at that point in time rather than the previous 3 months. Where things are changing is an interest in HbA1c testing earlier in pregnancy, because it does potentially reflect glucose levels prior to pregnancy or early pregnancy where we don't quite have that influence yet. And with some of the newer guidelines coming with ADIPS, there's been a lot of discussions about an HbA1c in that what we would typically say being sort of pre-diabetes range, actually calling that as early gestational diabetes. So that's where things are going from an HbA1c perspective. So HbA1c testing second trimester is not particularly helpful. If it is elevated, it'd be a bit surprising, but if it was, it'd be a bit concerning. But most of the time we find they're normal HbA1c levels and it gives us no information. An elevated HbA1c of 6.5% or higher is a diagnosis of type 2 diabetes. An HbA1c sitting between 6 and 6.4, there is a thought at this stage that we should be treating these women as possible early GDM, even though we would say in a non-pregnancy setting that they are pre-diabetes. So that's where things are sitting from an HbA1c perspective at the moment. In terms of early GDM, so Toboggan was a multi-centred Australian-based RCT, which actually occurred during COVID, so they did well to actually get things moving. The women that they screened in this, the women included in this trial were between 4 weeks and 19 weeks and 6 days gestation, who had a risk factor for hypoglycemia and a diagnosis of GDM per our ADIPS criteria. And they were either randomised to receive immediate treatment for GDM or deferred until a repeat OGTT at 24 to 28 weeks gestation, and then treated based on this repeat OGTT. And they were looking at all of the standard perinatal outcomes we'd be looking at in these sort of trials. So between these two particular groups, interestingly, a third of women with GDM on the early OGTT actually had a normal OGTT at 24 to 28 weeks. Which was an interesting finding. Again, I'm not too sure if these were women who had these OGTTs very early in first trimester. And so again, where that sort of leaves us from that perspective. And in some of their exploratory subgroup analyses, there was suggested that was particularly benefit for immediate treatment for women who had a higher level glucose of that higher band GDM on those initial OGTTs and in those who were identified earlier. So this has been, the overall result was that women who were treated earlier had better composite outcome than women who were treated, who had delayed treatment. Interestingly, this outcome was driven by differences in respiratory distress, not by differences in other perinatal outcomes. So this is still, I guess, being debated in terms of some of the significance. It's probably the best trial evidence we will have at this stage in terms of whether we treat early GDM or not. And the thinking is that we probably would look at treating early GDM, but it's still at this stage, it's I think the jury's a bit out on the significance. So GDM monitoring and targets, there's obviously different thresholds in different centres, and this is really just based on, I guess, a lack of evidence in this area. So these are what our standard fasting and 2-hour postprandial targets would be. When a woman is diagnosed with GDM, they would routinely see a dietitian, particularly because the specific advice which is provided is different from non-pregnancy and also general pregnancy advice, with the emphasis being on a low GI diet with a modified carbohydrate intake and aiming to achieve normoglycemia with some changes to dietary carbohydrates if at all possible. Now, in the interest of time, I might move through the nutrition section. In terms of insulin use, we would typically be using, regimens may vary from centre to centre. We typically use a basal bolus regimen for GDM management. So we typically would be using the Protophane Inlet device, which is given before bed, and this would be to manage fasting hypoglycemia, and then usually short-acting insulin, which would be given with the meal, and this would be dosed based on a 2-hour postprandial glucose level. I put the devices up there as certainly locally, we have a lot of women who do not speak English or have very poor health literacy. And one of the things that we find quite helpful is to describe what the insulin looks like. So whether it's the clock dial, white clock dial, or the insulin pen, in terms of working out what they're taking and what doses they're taking. And we find that quite helpful, as that Inlet device is quite unique to the regimen that we use, and also through Sandringham tends to use as well. In terms of some insulin treatment practical tips that we talk about with women in clinic, so particularly looking at the duration of fasting, looking at what time's the evening meal and what time's breakfast. We can find that prolonged fasting can cause an elevated fasting glucose, and this is due to that gluconeogenesis process kicking in. So sometimes we find that women who have a mildly elevated fasting glucose, instead, they may not actually require insulin, and instead if they added a pre-bed snack, that actually ends up helping those fasting glucose levels. Obviously, eating overnight and snacking, particularly managing nausea associated with pregnancy, has its own challenges, and shift work can also add to some challenges as well. So that's being a bit more flexible with what the insulin treatment regimens we're using.
Yeah, I was quite interested when I heard that our diabetes educators were saying, yes, have something to eat before you go to dinner, because it was counterintuitive. Yeah.
Yes, in terms of that, something a bit different. In terms of metformin use, so just very briefly, there is some metformin being used in some centres, depending on the comfortableness of the treating team managing the woman. We know that metformin does cross the placenta. However, there's no evidence of teratogenicity, and certainly if we're looking for GDM management, we're using metformin much later in pregnancy as well. The concern has been that there may be potentially a risk of small for gestational age risk with metformin use. Women with GDM usually would be having additional growth scans and additional monitoring. So certainly sort of our local practice is that if we've got a woman who's requiring significant insulin doses and there's no concerns for growth restriction, we can find metformin can be quite helpful. There have been there's been 2 randomized control trials recently that have been looking into metformin, and really the bottom line is being a bit more cautious in this question about SGA, but it can be useful in terms of managing escalating insulin requirements. For women who are refusing insulin completely, some women do manage to get away just with metformin, but it really depends on how significant clearly the hypoglycemia is. So really first line really should still be insulin, but in some patients we do try metformin to see if that has resistance.
I just thought it was worth, I think at all 4 centres, if somebody develops GDM, they actually come out of shared care, but shared care doctors and midwives play a pivotal role in actually supporting women both, continuing to support them in their pregnancy and also postpartum. Just a few things. At the women's, a few years ago, they did a study on women that were very well controlled on diet and looked at outcomes and found that their outcomes actually were as good as, if not better, than women that had low risk pregnancies. Has that been the experience at Western Health as well?
So yes, that doesn't surprise me, as I think that one of the most important aspects of women with gestational diabetes management through pregnancy is having continuity of care with the team that's looking after them. And unfortunately, one of the issues with public clinics is they may see a different doctor, a different midwife every time they're being seen. And these can be quite significant. Pregnancy in and of itself can be quite stressful. When we're adding on dietary advice, that it can be quite different to what normal diet's being done. Talking about, how are we going with exercise and some walking when you're feeling rubbish from nausea and vomiting and other potential things that crop up during pregnancy. We're talking about finger prick checks and the not so fun part about insulin injections and those sort of things. So it doesn't surprise me that women would be potentially more engaged with their primary practitioner that they'd be seeing pre-pregnancy and also seeing during pregnancy as well. I think we try as much as we can to have the same practitioners seeing the woman throughout pregnancy.
And the other thing that, as a GP think is valuable is that, women, certainly at the women's, we have those lower thresholds for control. So probably a lower threshold to go to insulin. But if women are only on diet controlled and well controlled, we don't actually increase their growth and wellbeing scans unless there's a clinical indication and they continue to go post-term as per requirement. So we don't alter that. That changes if people are on insulin, low dose insulin. Again, that sort of we tend to induce them a bit earlier, and if they're high dose insulin, a bit earlier again. And both people on insulin actually do get growth and wellbeing scans as routine as well as clinical indications. The other thing, just again, Jessica, just from a GP's point of view, that I always think is really important for women is that in subsequent pregnancies, my understanding is that the incidence of getting gestational diabetes is about 50%. So that 50% they don't. And I think that that's often very heartening for women as well.
Yes, no, definitely.
Thank you.
And yes, that goes very well into postpartum management. So yes, somewhere between 30 to 50% risk of developing GDM in subsequent pregnancies. Ideally for women after they've delivered, do need a postpartum oral glucose tolerance test at 6 to 12 weeks. And this is really to screen for any underlying diabetes that's been challenging, that's been unable to be identified during pregnancy. So there are guidelines in place for these women because we do know that they have an increased risk of developing type 2 diabetes mellitus over subsequent years. The frequency of screening really comes down to other risk factors for diabetes and also future pregnancy planning as well, where we'd be a lot more focused on screening and identifying a potential type 2 diabetes and optimizing glycemic control before becoming pregnant. So some couple of screening guidelines there. Now, in the interest of time, I just had one quick comment about pre-gestational diabetes. This is obviously a talk in and of itself, but just from a, I guess, a primary care perspective, what we see a lot more commonly at Western is women with type 2 diabetes and type 2 diabetes with even microvascular complications in their 30s. So these women are obviously of childbearing age looking at getting pregnant. And we find anecdotally there's often type 1 diabetes gets a lot of government funding and support with technology and all sorts of support from that perspective. But sometimes women with type 2 diabetes maybe get a little bit left behind in that sort of question. And we certainly do know, this is a very old paper from the 80s, but just showing that early HbA1c level association with percentage malformation of spontaneous termination, or spontaneous miscarriage. And there was just a recent, just an interesting study from the UK. Now they did a 5-year national population-based cohort study of all women with type 1 and type 2 across England, Wales and the Isle of Man. So it's 17,000 pregnancy and actually a pretty close 50-50 split with type 1 and type 2. And just some really interesting data here showing that particularly for some of the the concerning perinatal outcomes in this is that we had neonatal death rates were higher for type 2 diabetes. Congenital anomalies were reasonably similar, so 44.8 for per thousand in type 1, 40.5 per thousand for type 2. And one of the sort of the concerning features that came out from this particular cohort study was some independent risk factors for perinatal death. Was that third, HbA1c levels being elevated, which would be probably understandable, being in the highest deprivation quintile in terms of SES, having type 2 diabetes versus type 1. And there was some concerns that across that in women with type 2 diabetes, only a very small proportion were taking insulin or taking folic acid in first trimester. So there was a significant concern about women with type 2 diabetes entering pregnancy with very elevated glycemic control already, when clearly that organogenesis process is already happening. And this was just an interesting graph just to show that our sort of rates of, so in purple is type 1, red is type 2. We've got rates of congenital anomaly of or perinatal death based on HbA1c. The first graph is based on early first trimester levels, and we can certainly still see that curve and that significant risk. And then again, rate of perinatal death based on HbA1c levels as well. So just thought it was an interesting, obviously not in the UK, not here, but really it's something that I think locally we need to be I said, making sure that all our women with type 2, we're considering that preconception counselling in terms of getting glycemic control as good as we can get it before pregnancy, like we would for our women with type 1. So moving to thyroid disease in pregnancy. So we know that thyroid physiology changes do occur to meet increased metabolic needs during pregnancy. And there's just a little a graphic there just showing some of the changes. So we have an increase in the thyroxine binding globulin, which is based on, which is an estrogen effect. So we have an increase in TBG production and a decrease in, TBG clearance. So we have T4 and T3 production by the gland increases to maintain that adequate free thyroid hormone concentrations. The other big thing that happens is the stimulation of the TSH receptor by HCG. We know that HCG has a similar structure to TSH and therefore has weak thyroid stimulating activity. And we know that HCG is increasing soon after fertilization and peaking at that 10 to 12 week mark. So this is just showing, again, quite an old study from the 90s, but a nice graph just showing in the blue that HCG level going up during first trimester and then coming down. And then in orange, the TSH level consequently dropping and then restabilizing again. And this is just important to note because this is physiologically what we would say is a normal physiological response to pregnancy. And so if we are testing thyroid function tests early in pregnancy, finding a low TSH is probably is very likely to be part of that normal physiological process of pregnancy. So I think it's nice to see that graphically. When we look at TSH levels later in pregnancy, they probably are slightly lower than the baseline pre-pregnancy TSH, but obviously there's a big spectrum based on the population that we're looking at. In terms of the fetal thyroid, this begins secreting thyroid hormones at approximately week 12. We know that the fetal TSH receptors become responsive to fetal TSH and TSH receptor antibodies at approximately week 20. And the reason why this is very important to keep in mind is that early in pregnancy, we're really relying on mum's free T4 levels to provide bub with enough thyroxine for fetal development. So we know that TSH from mum doesn't cross the placenta, but free T4 does. So certainly if we have someone entering pregnancy with significant hypothyroidism, it's really from very early on that we're worried about those low free T4 levels. In terms of a patient with Graves, where we particularly start looking at the titer of the TSH receptor antibody is really later in pregnancy. But again, that's related to that particular antibody crossing the placenta. Perfect. So this is just a bit of a graphical way of showing it just in the top in terms of the T4 from mum and then crossing to then bub being able to develop it to make its own thyroxine. And again, just an older study, but just showing that this is very different in different populations based on, often based on ethnicity, BMI, but also iodine intake. But there's quite a range in what is normal TSH in first, second and third trimester, which then means that it's quite challenging for us to say what is a normal TSH and what is an abnormal TSH when we have blood tests that we have during pregnancy. So there's very few labs which provide reference ranges for thyroid function tests in pregnancy. But what we can see for those that do is that the thyroid stimulating hormone in first trimester, that reference range is allowed to be a lot lower than what we'd see in second and third trimester. So when we are talking about thyroid disease in pregnancy, thyroid function screening is not routinely recommended during pregnancy. And really, screening for thyroid disease really should only occur if we've got a patient who has symptoms that we're thinking could be in keeping with thyroid dysfunction, or if there's any significant personal history that would make you think this person is at an increased risk of thyroid dysfunction. From 6 weeks, the lab-specific TSH intervals should be used if available. Now, a lot of the pathology companies do not have these pregnancy lab-specific TSH levels. So what would normally be considered would be a TSH of greater than 4. It would be considered elevated. So looking at overt hypothyroidism, this would be defined as a mildly elevated TSH but with a decreased free T4, or with a TSH that's greater than 10, irrespective of the free T4 level. And then the subclinical hypothyroidism range would be, and I do apologize, that TSH should actually be, 4 to 10, not 2.5. Apologies, that. So what we normally say for subclinical hypothyroidism is a TSH greater than 4 with a normal range free T4. So in terms of hypothyroidism in pregnancy, clearly autoimmune or Hashimoto's thyroiditis is going to be the most common. We do still see patients who have had previous treatment for thyrotoxicosis, so either thyroidectomy or radioactive iodine, who may enter pregnancy on thyroxine replacement. They'd be the most common, and then a rarer would be some of those congenital and secondary hypothyroidism pictures. So this is clearly a challenging area to research. We do know that overt hypothyroidism needs to be treated early during pregnancy to reduce the risk of potentially severe perinatal outcomes and the adverse cognitive outcomes in offspring. We know that severe hypothyroidism is associated with cretinism due to iodine deficiency, and there has been some associations found in observational trials between untreated maternal hypothyroidism and a reduction in IQ in offspring. Importantly, this seems to be an inverse correlation between the severity of maternal hypothyroidism and in terms of other related perinatal complications. There's quite a list there. Again, this is a really challenging area to investigate, because a lot of the observational trials that do make comments on this, also these women often had other comorbidities as well, or other things going on. Importantly, although untreated or incompletely treated hypothyroidism can adversely affect pregnancy, there's been no data to suggest that a woman who's adequately treated has any increased risk of any obstetric complication. So I think it's really important for women who do have Hashimoto's hypothyroidism, who are on thyroxine entering pregnancy, to understand that yes, they will need a little bit of extra thyroxine during pregnancy, but this should have no change in terms of their pregnancy management, as well as just probably more frequent blood tests to confirm that dosing is appropriate. So our preconception target TSH for women with pre-existing hypothyroidism is less than 2.5, apologies. And generally what we would do is give patient education that when they find out they become pregnant, they should be increasing their weekly dose of thyroxine to 25 to 30%. This is usually, we would work this out based on their weekly dose, but often if they're on the same dose every day, this will be either a single weekend day dose being doubled. Tends to be an easy way to do this. If we have overt hypothyroidism, which is diagnosed early in pregnancy, then we need to aggressively be replacing the thyroxine due to those potential risks. And often this requires early endocrine input, because these women will need a lot higher doses potentially than if they were non-pregnant, due to the physiological increased thyroxine requirements during particularly early pregnancy. In terms of postpartum, most women will return back to their pre-existing thyroxine dose at delivery, and we usually would then recommend a further check at 6 weeks to ensure that the replacement is adequate. Now, just with subclinical hypothyroidism, I bring this article up as this is what, so the Melbourne Public Hospital's consensus, very important emphasis on the word consensus, but this is what's guiding a lot of the practice in Melbourne at the moment with when to diagnose and when to manage subclinical hypothyroidism. Importantly, this is an area that's got very poor evidence, and although we do have stronger evidence for treatment of overt hypothyroidism. The subclinical hypothyroidism picture is quite different. So there is, I've made a couple of comments there that there is sort of some possibility that subclinical hypothyroidism that's not treated may cause long-term effects on fetal brain development. This is quite contentious. The link between subclinical hypothyroidism and adverse pregnancy outcomes is very unclear. And we really don't have, probably one of the most accepted associations is between subclinical hypothyroidism and miscarriage. However, even here, the study findings are quite contentious. So really at this stage, the evidence is very poor. As a consensus base, decisions were made that thyroxine, a diagnosis of subclinical hypothyroidism is made based on a TSH of greater than 4, and that's when it would be considered to start thyroxine therapy. This is why it certainly doesn't fit with what our target TSH is. So once thyroxine's been treated, we aim a TSH less than 2.5. And explaining this to registrars and trainees as to why we have a different diagnostic threshold to what our treatment threshold is obviously quite challenging, but it reflects this as a really poor evidence-based zone. So this is what we recommend, what is, I guess, recommended. The evidence is very poor. There's certainly a thought that we are over-diagnosing subclinical hypothyroidism. I guess in terms of a treatment strategy, we know that thyroxine is safe. It's unlikely to cause harm. There may be some, I guess, stress caused in terms of increased monitoring during pregnancy, but I guess when we're weighing up the risks and benefits, there's a thought that maybe it's safer to give a small dose of thyroxine and aim to stop it at delivery. Yes, clearly it's a tricky area, and that we see a lot in clinic with questions about whether we treat or not treat.
We get a lot of questions in the hospital too, but I think that's a really good synopsis of it, which is a bit of an evidence-free zone.
Mm-hmm. So I think we do the best we can with what evidence we've got, with the, I think, assumption that probably the evidence base here is unlikely to change, because I think there's never going to be a controlled trial in this area due to the potential of risk, I would think. But
don't do it routinely. We don't want to find things that we don't necessarily know what to do with.
Now, I will, just in the interest of time, whiz through. We might just talk specifically about gestational thyrotoxicosis. So hypothyroidism in pregnancy, we've got specifically gestational hypothyroidism or gestational thyrotoxicosis. It's got about 5 different names. Graves' disease is the other important differential to consider. And then we've got obviously all our other a whole list there of rarer causes and that are less likely to come up. Distinguishing Graves' disease from gestational hypothyroidism can clearly be quite challenging, and that's probably the biggest thing that we often base our diagnosis on, is really whether there's the presence of TSH receptor antibodies being present or not, although you can get patients who have Graves' disease and get gestational thyrotoxicosis pictures as well. When we talk about gestational hypothyroidism, and I've given a lot of other synonyms up there as well, this is related to, so the beta-HCG, or that molecular variant proteins related to beta-HCG, they bind to the TSH receptors on the maternal thyroid, which displaces maternal TSH. The binding affinity of beta-HCG is significantly less than maternal TSH, but extremely high beta-HCG levels will overcome maternal TSH. So we often find this is associated with hyperemesis gravidarum, which tends to be with pregnancies that have much higher beta-HCG levels, and then other conditions that are associated with higher HCG levels, such as twin pregnancies and rarer high data for moles and choriocarcinomas, but particularly multiple gestations as something we'd see more commonly. So the excuse me. So the TFT, the thyroid, so what we tend to find is that the thyroid abnormalities can be significant, but they usually are limited to the first half of pregnancy. And we tend to see this in women who have significant hyperemesis. So although it can be challenging to differentiate from Graves', what the important thing to note is gestational hypothyroidism really will resolve with time in terms of the thyroid dysfunction, and that we don't usually need to be giving any anti-thyroid drugs in this particular setting. Sometimes we do give beta blockers if we think symptoms are particularly concerning or worrisome to the woman, but usually supportive therapy is all that's required.
So Jessica, just doing, because that comes up a lot in general practice too. So if you find that the TSH is quite low, even for that area in pregnancy, if you do receptor antibodies and they're fine, just take somebody off their iodine replacement and give them supportive control, and then just repeat it in, 4 weeks or so, would that generally be the case?
Yes, yeah, and that's a very good point about pregnancy multivitamins containing iodine. So yes, I do apologize. Yes, we normally would reconsider iodine containing multivitamins. If the antibodies are so if we have a TSH receptor antibody that is negative, it is very unlikely to be Graves, which is of course the diagnosis we want to be making, particularly early in pregnancy, due to concerning consequences from that. There are cases of antibody negative Graves, just to muddy the water a little bit, but generally speaking, if we've got negative TSH receptor antibodies, we've got mild TFT derangement that on repeat serial TFTs, even if we're very worried, a couple of weeks apart rather than 4 weeks initially, this would all be in keeping with a gestational thyrotoxicosis. So the most important element to note is that a TPO antibody is not being used to differentiate Graves and gestational thyrotoxicosis. When I'm talking about antibodies, I'm speaking specifically about TSH receptor antibodies or TRABs in this particular setting. Now, in the interest of time, I think we'll leave Graves' disease for today. It's obviously an important condition, and in pregnancy and postpartum, and I think there's probably maybe a bit much for today. Probably the one comment I will make is that preconception counselling is incredibly important for any women with pre-existing Graves, and that due to significant concerns about not just miscarriage risk and I guess fertility in the first place for uncontrolled Graves, but certainly there are a lot of concerns about outcomes during pregnancy for women who are on high-dose antithyroid medication and do become pregnant or have uncontrolled Graves prior to becoming pregnant. So I think this is an area that we need quite close integration with primary care and endocrinology to optimise thyroid function prior to getting pregnant, if at all possible.
And also some of the medications contraindicated, is that correct?
Yes, so it can be quite a challenging area of balancing the potential teratogenic side effects of antithyroid drugs, but also the risk of miscarriage and symptoms from a thyrotoxicosis perspective to mum without being on these medications. So it can
definitely
be
referring to an endocrinologist from my point of view. Me.
Yes. Okay, and subclinical hyperthyroidism in pregnancy, we've really already mentioned in terms of looking at thyroid hormone physiology changes in pregnancy anyway. This is a common referral we see from time to time where a woman is referred with a low TSH but a normal range free T4 or free T3. Often this is very early in pregnancy, and we would follow these women up often with maybe 4 or 5 week thyroid function tests just to confirm that there's nothing evolving, but there's no evidence that there's any harm to mum or bub with a normal range free T4 or free T3 with a low TSH. Usually this will resolve. There are a couple of, we do see a handful of patients that may still have a low TSH postpartum, and then in that case we would be non-urgently looking for other reasons. They may have subclinical hypothyroidism, which may come to being a nodule or a multinodular goiter or something like that. Regardless, early in pregnancy, this usually is not a concern with a normal free T4 and free T3. So postpartum thyroiditis is just the final topic that I wanted to cover for this evening. So this is an inflammatory autoimmune condition, typically occurs anywhere from about 2 months postpartum. And we've got classically, we see the transient thyrotoxicosis followed by transient hypothyroidism and then a return to euthyroid state. There are some women that will present with just isolated thyrotoxicosis and others just with isolated hypothyroidism. There is also a group of women who will have persistent hypothyroidism ongoing. So in terms of risk factors, this comes from women who do have TPO antibodies that are tested in pregnancy. So for a woman who's diagnosed with hypothyroidism during pregnancy, we would usually check TPO antibodies as if they are positive, be suggestive of Hashimoto's, and these women are at increased risk of postpartum thyroiditis in future. Also women who have already got risk of autoimmune conditions. In terms of, interestingly, women with previous history of postpartum thyroiditis, there's a 70% chance with future pregnancies as well. So in terms of presentation, usually this is a painless thyroiditis, so this is not so usually no neck pain. The thyrotoxicosis phase for most women will be asymptomatic or quite mild. And with that, most women won't require any symptomatic treatment. Sometimes we do use beta blockers, but for many women, it's more just following with routine blood tests to mark their course. The hypothyroid phase is frequently more symptomatic and often does require some thyroxine replacement. In women who are at risk, and these sort of women probably are already having thyroid function tests at 6 weeks postpartum anyway, but that's when we would be doing an initial test to see if we would assess for thyroid dysfunction. For women, and this is quite challenging obviously for postpartum, but women who have other symptoms potentially in keeping with postpartum thyroiditis, we'd also be checking their thyroid function tests. Obviously, it'd be quite challenging in the context of other postpartum understandable symptoms as well. Postpartum thyroiditis versus Graves can also be challenging to differentiate. And why this is important is because postpartum thyroiditis, typically we'd be managing conservatively initially and monitoring for that hypothyroid phase for when we'd be starting potentially some thyroxine, while Graves would be needing to look at anti-thyroid treatment. So again, we do rely a lot on those TSH receptor antibodies, and if they're positive, that would be certainly indicative of a diagnosis of Graves. And it is possible to do some technetium scans postpartum, even with breastfeeding, and that can be discussed with nuclear medicine departments to organise precautions for that. That'd be an uptake scan looking at the gland. We tend to see a lot of significant uptake with Graves because it's quite a hypervascular process, while with thyroiditis there tends to be very little uptake. So I think we've covered treatment just very briefly. So your thyrotoxic phase, mainly just beta blockers if required, and hypothyroid phase. Some women do get away without thyroxine, but we tend to start thyroxine, particularly as these women do tend to get symptoms, and it can be very challenging to determine whether the symptoms are hypothyroid or not, but regardless, there's probably benefit to treating. I might leave it there for the moment, just with the interest of time. Were there any questions?
Oh, yes, there are lots of questions. Did you want to just do, probably cover a few of them. There are a few questions about women that are on metformin for PCOS and go into pregnancy. So a few questions about, should you continue the metformin? And is there any benefit in continuing the metformin for women with PCOS?
That is a great question. We often see women who come as referred with GDM on their oral glucose tolerance test, having stopped metformin when they've found out they're pregnant, and there's a big question raised as to whether they can have their metformin restarted at the 24, 28 week mark for GDM management. Look, I think at the moment, we think metformin probably is safe in pregnancy, but I think there is still a thought that there is this question mark about a potential risk of SGA. I think that, look, me personally, I think once probably the woman's pregnant, practically speaking, we often see that the metformin would be ceased. Would that prevent GDM in future, or would that improve your oral glucose tolerance test? I think it's a very good question. I think probably our practice at the moment would be we'd have women off the metformin. They'd have their testing done if they are diagnosed with GDM. Women who have pre-existing polycystic ovarian syndrome probably are at higher risk of needing much higher insulin doses for their GDM management. So I must say potentially metformin being used in their treatment would be something.
Unless they need it. And there was a question also about women on metformin for diabetes and whether we should stop it. And certainly for women's, the general recommendation is let us know really early. Obviously, anyone with diabetes, you want to control that fantastically before they get pregnant. If they're on metformin and they're pregnant, don't stop the metformin. Let us know, and we'll get the diabetes educators going soon, and they might well change to insulin. Is that your experience too?
So I'd 100% echo that. And I think our biggest concern is that we often see women who are diet controlled or well controlled on metformin from what they're reporting, but in actual fact, when we look at HbA1c levels, they're well above the pregnancy target of less than 6.5%. So a lot of these women need to be started on insulin if they have not already been started on insulin prior to pregnancy. I know that's a big sweeping comment and very reflective of probably being out west, and just with some of the population out there, just with some of the ethnicity, there's a lot of insulin resistance. But we often find for pre-existing type 2 diabetes that have not already been on insulin, we often need to start insulin very early in pregnancy to manage hypoglycemia and really, and just because we're aiming such tight pregnancy targets. So these women should be 100% flagged as urgent endo reviews. We should be seeing them in first trimester.
So just probably 2 more questions, and then what we'll do is take the rest of the questions, get some answers, and send them out with the pack, which would be great. So the first one is centered around, people that don't want a GTT, which is actually increasingly happening. So let's go postpartum first. So, that postpartum 6 to 8 week check, for sometimes the GTT, we always sort of suggest a GTT, but that's sometimes hard for women. How hard should we push that sort of GTT? Should we just move it to sort of 12 weeks when it's a bit better for them to actually get a GTT, or is it okay to do a HbA1c and fasting blood glucose? And then the next question is, if it's normal, what do you do every 2 or 3 years? Do you do a GTT? Do you do a HbA1c and fasting blood glucose? And how often do you put it in your rectal system?
Yeah, really good questions. Look, I think the reality is we assume it's very poor uptake for postpartum OGTTs, but I don't think we've got the evidence base to say that. I know Adelaide tried to do a big survey, a survey study a couple of years ago to try and work out what the follow-up was of postpartum OGTTs, and it was very poor. My thinking would be anything is better than nothing, and I think if 6 weeks is a really rough time from the postpartum perspective, I think having the testing done at 12 weeks is certainly a fantastic outcome. And certainly during COVID, not that we say COVID was showing best care for maternity care in particular, but in COVID, there was very little concern with being a lot more generous with saying, doing the oral glucose tolerance test up to 12 weeks to sort of give a bit more of a buffer for that time follow-up. I think doing an HbA1c early postpartum is not going to be helpful. That's why really there should be a push for an oral glucose tolerance test, not for an HbA1c. And I do think it is really important that we are answering that question as to whether or not that woman has got any underlying glucose intolerance, particularly because we do find that a lot of women have not had any testing and then they become pregnant again. And then we've really missed that opportunity to potentially both diagnose but also manage prior to the next pregnancy in terms of both her risk as well as Bub's risk.
And if it's a completely normal GTT, would you do that every 2 or 3 years and just a HbA1c and fasting blood glucose?
So I think there's a move to doing HbA1c testing. It did used to be, I think a lot of the guidelines would be saying oral glucose tolerance tests every 1 to 2 years if the woman was looking at trying for, as part of sort of preconception planning, looking at oral glucose tolerance test. I think now with more reliance on HbA1c and fasting plasma glucose, that would be an adequate screen.
Every 2 years?
Every 2 years.
Yeah. And if somebody doesn't want one at the 24 to 28 weeks, I mean, we all have women that either don't want it or vomit it up. If they vomit it, the classic thing at the women's is offer it once more to see if they'll have it. And then the question is, if they won't have one, do you offer them a week of QID testing? What happens at Western? Because it's a bit of a variable approach, I think, everywhere, even within an organisation.
Yeah, look, it certainly is, and it's a topical question because that's what we're actually looking at in my we're trying to get a randomized control trial up and going, comparing the simplified screening during COVID, which was doing a triaging fasting plasma glucose to then determine women having an oral glucose tolerance test, whether having the oral glucose tolerance test as a universal screen. There's clearly no evidence to guide what do you do with a woman who doesn't want to have an oral glucose tolerance test for whatever reason. And certainly locally, because our network did take on board the simplified screening during COVID, we now have women returning for their subsequent pregnancy saying, I didn't need to have one last pregnancy. Why do I need to have one this pregnancy? What we routinely offer would be a glucometer and 2 weeks of finger prick checking. Now, it's tricky because we're obviously not, this isn't a validated screening tool. We're not giving someone a specific glucose load and trying to diagnose it based on those diagnostic thresholds. Instead, we're really looking at treatment targets when we're doing finger prick checks. So I think it's better than nothing, but it can be quite challenging to then interpret the finger prick checks as to, if someone meets criteria for treatment, then that's great. They clearly have gestational diabetes. But when we're looking at,
that's the practice at the women's too, but it's a bit variable about women picking it up. And they also, there's a cost issue with regards to the.
I was going to say the other thing is we don't apply the glucometer. It's the woman has to go to a pharmacy and pay for it herself. which
So
is...
one last question. It's been a fantastic presentation. I've learned so much, Jessica. Great. Just with regards, and I've seen it as well, is that, you know, subclinical hypothyroidism, or actually not even subclinical, and fertility specialists, particularly putting people on thyroxine. What's the evidence for the link between fertility and true subclinical hypothyroidism as opposed to hypothyroidism, or just upping the thyroid?
My understanding is very, very poor.
Was my understanding too.
Probably an intervention that has very little harm. So I think that's possibly why if people decide to start it.
That's right.
But I think the thing that we see locally is, so out west, women with, particularly we've now Bacchus Marsh is now part of the Western Health conglomerate, and we find women who now get referred to Sunshine to deliver because they are unable to deliver at Bacchus Marsh if they're on thyroxine for subclinical hypothyroidism. So that's something that's a new thing in the last 6 months. It's being looked into and reassessed, but that's sort of showing that we are medicalising a pregnancy where, what is the benefit?
I agree. And there's a few questions about, you know, do you repeat it if it's subclinical? And I think what we're saying is that there's very poor evidence. Think about doing the test and whether you do need to do the test, and then think about that approach. It's only consensus-based, and we're not so sure about that, and it's not so linked to evidence, but and stop it at the person's had their baby. Jessica, what we'll do is collect some of these answers and send them around later. And thank you so much for that excellent presentation.
Thanks for your time.
Thank you very much. So now I'm just going to share my screen. Bear with me. So I just wanted to introduce Vanessa. Thank you very much, Vanessa, for being with us this evening. Vanessa is a clinical and laboratory haematologist with a special interest in antenatal and obstetric haematology, including prenatal counselling and investigation of thalassemia, hemoglobinopathy, and she currently practices as a consultant haematology and medical obstetric physician at Northern Health and Mercy Health. So thank you very much for being with us this evening, Vanessa. I'm very much looking forward to this.
Thanks, Ines. I might try and share my screen.
Stop mine. Perfect.
Yeah, just give me a sec.
Can't see you. Yeah, that's great. It's not in slideshow.
No, I'll just...
Perfect.
All right, is that all up and running?
Perfect.
Excellent. All right. So, yeah, thank you for having me on tonight to present. I'm hoping to provide actually more of a practical perspective on haematology in pregnancy. I apologise in advance if I talk really fast. I've got quite a lot to get through in the next hour, particularly looking at anemia in pregnancy, focusing on iron deficiency, antenatal thalassemia screening in primary care, thrombocytopenia in pregnancy, mainly looking at ITP versus gestational thrombocytopenia. And if we have time at the end, a little bit about venous thrombosis, the diagnosis and initial management. So if we start off with anemia in pregnancy, it's really the most common haematological disorder in pregnancy, and about 25% of pregnant women in Australia are anemic. And it's important when you're looking at anemia in pregnancy to actually look at the gestation. It does change throughout the gestation, where in a non-pregnant female, a haemoglobin of less than 120 would be defined as anemia. But by the time you get to sort of second and third trimester, that drops to about 105 to 110. Suffice to say that any hemoglobin at less than 100 grams per litre at any stage of pregnancy or postpartum is anemic. And just be aware to check the reference ranges of your laboratory because it might change. And the reason for that drop is really because of physiological anemia. So your plasma volume expands more so than your red blood cell volume. So we do expect a slight drop in hemoglobin throughout pregnancy. The causes of anemia in pregnancy are similar to those that are non-pregnant, and I like to separate them in three categories. Is there blood loss? Is there increased red cell destruction? Or is there a decreased red cell production? And increased red cell destruction, we're essentially talking about our hemolytic anemias, whether inherited or acquired. And with decreased red cell production, we're looking at mainly your hematinic deficiencies, bone marrow disorders and so forth, quite rare in young females, present but rare. But just to notice that 90% of cases of anemia in pregnancy are due to iron deficiency, and it is the most common cause of anemia that I see in my practice over at the Northern Health and over at the Mercy Hospital. And why is that the case? Most of our women have low iron stores prenatally, so their iron stores aren't optimized before they get pregnant, so they're at a deficient state beforehand. During pregnancy, the physiological demand increases 3 times than you would in the non-pregnant state, and that's due to the expansion of the red cell mass and the requirements by the uterus and the placenta. Fetus, the baby, takes as much iron as they like, even if you're iron deficient. So baby will continue to take mum's iron. And we also want to be able to have enough iron stores to replace any blood loss at delivery. In addition, during the 2nd and 3rd trimester, iron absorption in the gut is really not enough to meet that increased demand towards the end of pregnancy. And overall, throughout pregnancy, you need about 1,000 to 1,200 milligrams of iron throughout the entire pregnancy. So it is quite a significant amount of iron. So it's not unreasonable that many women are iron deficient. Does it really matter? Does it matter that they're iron deficient? There are some maternal effects where women will describe, I feel really tired, I'm fatigued, I've got no energy, reduced mental performance. It's a well-known fact that they're poorly tolerant to blood loss at delivery if they're anemic. There's increased probability of blood transfusion and an increased risk of postpartum depression or emotional instability. If you have severe anemia, then there can be adverse pregnancy outcomes, such as increased rates of prematurity and IUGR, and that's in the cases of severe iron deficiency anemia. The jury's out really about whether there are fetal effects. There are some studies that suggest that is there some cognitive or impaired psychomotor or mental development in offspring in iron deficient women, and that's still debatable at this stage. So I'd like to present a case of a 29-year-old female from Sri Lankan background, G4P3, who's 6 weeks gestation, and you organise her booking bloods, and haemoglobin's borderline, 110. She's microcytic with a MCV of 78, and as you can see are her iron studies, where she has a low serum iron, normal transferrin, low transferrin saturation, and a ferritin of 42. So the question is she iron deficient? So let's break this down a little more. So in order to look at iron deficiency, really need to look at a thorough history and consider the causes of iron deficiency. And there's lots of factors in play, dietary factors, social factors, demographic factors that would place a woman at risk of having iron deficiency. What to look for essentially, is there any issues with chronic blood loss, particularly GI bleeding disorders, which you probably should be aware of or would be aware of before someone's pregnant. There's increased demand from pregnancy. Is there a history of malabsorption of iron? So have they had any bariatric surgery, gastric sleeve, for example, or do they have inflammatory bowel disease? Or are they a vegetarian or a vegan, and where they don't take in enough iron? And by far the most common cause for me in practice is that they're already iron deficient because they've got menorrhagia, or they're vegetarian and they just don't eat very much iron in their diet. Then we look at risk factors. So the younger a person is, if they're multiparous, they've got previous iron deficiency, if they've had lots of kids in a short period of time, they come from a low social economic status, poor nutrition, and nationality. So all of these things are more predictive of whether someone is at risk of being iron deficient. Then we next look at sort of diagnosis of iron deficiency, and we look at the FBE and the iron studies. And the clue is really in the indices of the full blood count. And women may be anemic or not. So if they're not anemic, we consider them an iron deficient state. whereas if they're anemic, iron deficiency anemia. And the MCV and the MCH are two parameters that you could look at that will give you a clue as to whether someone is iron deficient or not, or at risk of being iron deficient. The MCV looks at the size of the red cells, and the MCH looks at the amount of hemoglobin in the red cells. And when they're reduced in size, and as well as the reduced amount of hemoglobin, you could be pretty confident that someone is either iron deficient or they have thalassemia or hemoglobinopathy. And just to put a note out there that, if you do see someone, we'll move on to thalassemia down the track, but if they're anemic or they have a low MCV or MCH, or they're from a high risk demographic area for thalassemia, I would recommend that you request hemoglobin electrophoresis and DNA studies, as well as the ferritin if you see a low MCV and MCH. What about the iron studies? Serum iron fluctuates with an oral iron load. So if they've had a big iron meal the night below, or if they've had iron supplements, or at the time of day that the iron studies are taken, that serum iron will fluctuate. Transferrin is a carrier molecule for iron. It signifies the amount of iron that's being able to be transported in the blood. And it is increased in late pregnancy due to estrogen, and can be falsely low in acute and chronic disease. Transferrin saturation is actually a calculated result looking at total iron binding capacity. Essentially, a low transferrin saturation would be consistent with low iron being available and iron deficiency. But really, all of those parameters are not specific or sensitive enough to diagnose iron deficiency. They can be helpful, they can give you clues, but essentially the serum ferritin is the main reflection of what your iron stores are. There's nothing else other than iron deficiency that will give you a serum ferritin less than 30. So if ferritin less than 30 is iron deficiency. Then it's a little more grey. If a ferritin is between 30 to 100, you can still have low iron stores if you've got underlying infection and inflammation. And that's where doing a CRP and the history will come into play. But we go back to this case where this patient is not anemic yet, borderline hemoglobin, microcytic, and her ferritin is 42. We organise a CRP. It's 5. She's not particularly, we don't think she has any signs of infection or inflammation. She's got several risk factors. She's had shortened pregnancy interval, and she doesn't eat very much red meat. She's microcytic with a normal ferritin. I would not classify her as iron deficient, but she's at risk of developing iron deficiency throughout her pregnancy because of that increased iron requirements and the fact that she doesn't eat very much red meat. And I am questioning whether she has thalassemia and request hemoglobin electrophoresis. So we repeat the FBE and iron studies at around 26 weeks, and at the Northern Health, and I'm sure most centres around Melbourne, we would repeat the FBE and iron studies around 26 to 8 weeks. At the Northern, we also repeat them at 36 weeks in all antenates. So by 26 weeks, not unexpectedly, she's still borderline anemic, but her ferritin has dropped to 15. So what do we do now? How do we manage iron deficiency? It really depends on what the severity of the anemia is, depends on what the gestational age is, and also depends on if there's any other additional risk factors. So initially we may start with dietary advice and iron supplementation. Dietary advice essentially that I provide is really to eat red meat. The redder the meat, the more iron there is, as opposed to non-heme iron from vegetables and cereals. The gut just doesn't absorb that iron very well. I ask the women to try and take some vitamin C to assist with absorption, and to try and inhibit foods that interact or inhibit absorption of iron. So calcium or dairy products, having a tea or coffee in the morning, and magnesium is another one that can inhibit iron absorption. So I usually ask them if they can take it on an empty stomach first thing in the morning and wait about half an hour before they have their morning coffee, if possible. What we know is that if you modify your diet, increase red meat and so forth, it can help prevent iron deficiency. But once you're already iron deficient, dietary supplementation is not enough. You really need to move on to some sort of iron supplements. It's just not going to increase those iron stores. And you'll be well aware of the amount of iron supplements that there are out in the market. There's well over 100 different types of oral preparations. What you essentially need to prevent iron deficiency is about 30 to 60 milligrams of elemental iron. And what you'll see from the table on the right, a table of various supplements that I like to use because they do have a significant amount of elemental iron. You'll see on the right-hand side. The guidelines would suggest that you need 100 to 200 milligrams of elemental iron a day for management of iron deficiency, and most women will not tolerate that much iron. It constipates them, makes them feel nauseous, and they just don't feel well on it. And there are some studies recently that have shown that really 40 to 60 milligrams is probably enough to correct iron deficiency, and anything more than that is really just adding to side effects. And also to be aware that most natural preparations, as you'll see on the smaller table, really don't have enough elemental iron. So when the antenatal woman says to you, I'm taking iron supplements, I always ask them for the brand of what they're taking and double check what the elemental iron is in that supplement. Also to be aware that Elevate, which is the common supplement that women are on, does have quite good amounts of elemental iron, but it does have lots of other vitamins and minerals, including calcium and magnesium, which can reduce the absorption of that iron. So if someone's iron deficient, I would prefer them to actually be on an iron supplement on its own rather than mixing it with all the other sort of multivitamins. What advice do I give them? I actually ask them to take it every second daily or every 2 to 3 times a week. And they can then titrate it to once a day as tolerated. And that's really to reduce the side effects of constipation. Studies have shown that such lower doses can be just as effective as the higher doses. And it actually probably maximizes iron absorption due to the alteration of hepcidin levels, which is a hormone that regulates iron absorption. So it may seem a little counterintuitive, but women that are taking iron every day, I do sort of suggest to them, why don't you just take it every second day or 3 times a week and take around 40 to 60 milligrams, and we'll see if that how that plays out in 4 to 6 weeks' time. I've mentioned most of this already. Take it in the morning, empty stomach with vitamin C. If they have some gut intolerance, take it with food or at night. Something is better than nothing. So if they need to take it with their morning coffee, you can give that a go. But this is sort of, I guess, the optimal way to advise them on how to take iron. And you might find that once they're taking it properly and the right dose of iron, that you might see some changes in their ferritin. So if we go back to the case, we advise the patient to take Ferrograd daily, second daily, and we repeat the iron studies in FBE at 30 weeks gestation. Not unsurprisingly, the ferritin's dropped to 10 and the hemoglobin's 90. She describes constipation with oral iron, and you decide to refer them on for an iron infusion. So what are the indications for an iron infusion? Essentially, those that are intolerant to oral iron or unable to absorb iron orally. So those that have had gut surgery, gastric sleeve surgery, other bariatric surgery, they really won't absorb the iron properly. So those patients are more likely to give an iron infusion earlier on. I'd like to give them a trial of iron 4 to 6 weeks before considering an iron infusion, because it's not without risk. Patients that are iron deficient with anemia that are near term, so if they're around 36 weeks or maybe more than 34 weeks, there's not enough time to try that oral iron. So in that situation, we would move on to an iron infusion rather than trialing the oral iron. And of course, if they've got anemia, so if their hemoglobin is less than 100, they're really not going to increment sufficiently on that oral iron, and we usually suggest an IV infusion. Contraindications for IV iron are first trimester, so please avoid in the first trimester of pregnancy, and those that have had a history of anaphylaxis to IV iron. What types of iron do we give? Most commonly we give iron carboxymaltose in the hospital setting. There is some increasing data of the use of iron maltose as well during pregnancy. The side effects are essentially minor, other than ferric carboxymaltose have increased risk of fishbone reactions, which is not an allergic type reaction, but it feels like one. And there's a less than 0.1% risk of severe anaphylaxis. And with that, there is a risk of preterm labour. So we would essentially recommend for any IV iron infusions during pregnancy to be given in the hospital setting rather than in the primary care setting. Also to be aware of the very rare side effect of skin staining, which can be permanent and for a young woman can be considered quite disfiguring for them.
Thank you.
So,
I mean, that's a great synopsis, because we certainly get a lot of requests for IV infusions, and it's gone up a lot. And quite a lot of them we're rejecting because it's exactly the same as you've said. You know, you've got to have adequate iron, not in the first trimester. And also that, you know, unless there's a reason you think that the woman's going to bleed, she needs to actually be anemic. So I just encourage people to, you know, that sort of advice about how to take iron is really important. And don't raise women's expectations that they will get an IV infusion. It will be triaged at all of the hospitals to see if it actually meets criteria. And as you've said, you know, even the safety profile in second and third trimester on the fetal liver is not fully established.
No.
So we're always better off if we can doing orally. Thanks, Vanessa.
Thanks, Inez. All right, so we move back to the case. So you refer for an iron infusion to the local hospital. You do get the haemoglobin electrophoresis back on the patient, and as you suspected, she has beta thalassemia trait. So what do you do now? Well, we need to request partner screening, really, to have a look at what the risk is to the offspring. So you request partner screening on baby, and the partner's haemoglobin is good, 130, with a normal MCV and a normal MCH. You think, okay, that's great, but you get the haemoglobin electrophoresis back and they're a sickle cell carrier. What do I do at this point? That's what I do at this point, because usually by the time I see them in the hospital setting, it's generally over 20 weeks gestation, and there's not much I can do other than counsel the couple that they might have a 25% chance of a baby with a significant hemoglobinopathy, and it would have been nice to have been able to know about it sooner so that I can do something about that. With thalassemia, it's the most common inherited abnormality in the world. It's detected in approximately 6% of patients of reproductive age, and it's due to essentially alpha and beta chain imbalance in the red cells. The severity of the condition really depends on the number of abnormal genes involved, the type of mutations, and the ratio of alpha to beta globin chains. And depending on the mutation, the syndrome can have adverse maternal and fetal effects. So there's quite a lot to sort of unpack when it comes to thalassemia. How do we detect it? Look, many will have a low MCV or an MCH, but they may or may not have anemia. So as I alluded to in the previous case with the partner, from an FBE perspective, you would not have thought that he had a thalassemia or hemoglobinopathy, but in situations like sickle cell trait, they can have normal parameters. It's important to look at family history and at-risk ethnic groups. And as you can see from the graph, it's really high-risk endemic areas are those around the equator, so Mediterranean, Indian, African population. But with the way people have moved around the world, really thalassemia is prevalent in all parts of the world. Diagnosis requires hemoglobin electrophoresis, which will detect generally most betas and some alpha thalassemias. But in order to detect alpha thalassemia, you need to request DNA studies. So why do we do antenatal screening for thalassemia hemoglobinopathy? Well, we really want to identify, we want to screen them, and we want to be able to offer them counselling before 20 weeks, well, really before 14 weeks, where we can give them the option of whether they want to have any prenatal testing or if they want to continue with the pregnancy or not. So who do we offer screening to? We offer screening to those that have a history of unexplained anemia, if there's a family history of anemia or known hemoglobinopathy, if they belong to an at-risk ethnic background, so those patients around the equator, and in all women that have an MCV less than 80 or an MCH less than 27 picograms. At the Northern Hospital, if you're in our catchment, you'll notice that for our patient population, that all antenatal women are screened and requires hemoglobin electrophoresis prior at their booking bloods. And that's really because about 90% of our population come from a high-risk demographic area. And often by the time you do their screening, you do partner screening, and they're seen, 16 weeks. By the time they see me, the haematologist, it's after 20 weeks. So essentially, preconception diagnosis is crucial. So if a woman or couple come to you looking at becoming pregnant, looking at what is their thalassemia risk, and primary care has the most important role with antenatal screening here. I'm sort of at the back end of screening, unfortunately. So you do have the most important role in looking at those at risk and organising that early screening. And as I've mentioned, we want to be able to do all of this before 14 weeks, and we don't get often a referral in place until 14 weeks in hospital. So what should you be doing in primary care practice, ideally prenatally, but at the confirmation of pregnancy is looking at their history, their nationality and their ancestors, looking at their family or their partner history and risk factors, looking at their past FBE results. So have they had a microcytic hyperchromic anemia, or do they have a low MCV, MCH? Ask if they've had testing for hemoglobinopathy in the past. We don't need to repeat it, it's genetic. So if they've been tested before, we don't normally need to repeat it. It's just trying to find the original copy if possible. And if you do have an antenate that has thalassemia or hemoglobinopathy, try to do the partner testing and confirm their status early on before they even get to see us in the hospital setting, because testing takes time. It takes several weeks and to get a result and so forth. What tests do you order? Essentially, you need to order FBE, iron studies, hemoglobin electrophoresis, and DNA alpha gene studies. And if there's a positive result, you request the same thing in the partner. But make sure you write the partner details on that, because in the laboratory, we do try and match up the antenates and the partner. And when you'd send it off to Monash to do the DNA testing, they do actually marry up the couple and can give you a combined couple report and risk factor report. If you have a really high clinical suspicion and the woman's already 8 weeks, you could just move on to doing partner testing at the same time, because it'll be several weeks before you get both of those results back. So this is an algorithm, and hopefully it's not too confusing about when to refer to haematology. And not everyone with thalassemia needs to see a haematologist, although we're more than happy to see them. So essentially, if you arrange an FBE, hemoglobin electrophoresis and iron studies on the antenate, if she's got normal FB and hemoglobin electrophoresis, you don't really need to do anything else. The caveat to that is that you will miss some carriers of single gene alpha deletions that may not be detected. Just to be aware that this is a screening process, not a diagnosis, so we can't detect everyone, but we want to try and screen as many as we can. If they have a low ferritin, I would still proceed to partner testing, because you can't tell whether the low MCV or MCH is due to iron deficiency or thalassemia, and treat their iron deficiency. If they've got an abnormal FBE and abnormal hemoglobin electrophoresis, or just an abnormal hemoglobin electrophoresis, move on to partner testing. If partner's normal, really the overall risk of the couple having a child with a severe thalassemia syndrome is very low, and they generally don't need to be referred for genetic counselling. But if they're anxious or worried, by all means, send them along. But if there's an abnormality in partner, then they really do need to be referred to see us. So as you can see, it's really the partner testing that holds the key as to what's going, where we head further down the track during pregnancy. Now, I've sort of rushed through a bit of that, and I wasn't sure if there was any questions before I move on to platelets in pregnancy and thrombosis.
Yeah, there's a few that I've answered as well, but I'll just this one's interesting. Should pregnancy be avoided soon after an iron infusion?
No.
No, okay. Just there's often a prudence, no one knows, but just no.
So we don't know, but the issue with the iron infusion during pregnancy is really the reaction during the infusion. So you're just going to have high ferritin and high iron stores. It won't cause any problems.
And, there are a few questions here just so that, I can see if you agree with me, which is, what do you do if, you're not iron deficient, you're not anemic, but the woman won't tolerate iron. And I've said, look, to some ways that's a classic general practice issue, is just working out why the woman's not tolerating it. If it's constipation, it might be increased fluid and having fibre. It might be encouraging her to go slowly on the iron, as you've said, or increasing her heme iron account. Would you agree with that, Vanessa?
100%, Inez. It's about holding their hand and getting them through that, because often they're taking either too much iron or they're taking it on an empty stomach, which is what we want them to do. But if it's causing nausea, then take it with food. If it's causing constipation, take some prune juice and some fluids and some, every second or third day. It's just trying to get them through that. And look, a lot of women are taking their iron properly, and they're not going to increment their ferritin. And unfortunately, there's not much we can do during the first trimester. You can correct iron deficiency prenatally, great. But I do get referrals in that first 6 weeks, 8 weeks with iron deficiency. And we just have to hold their hand until after their second trimester.
And there was a question there about, multiple taking it with food. And as you've said, you have it up without food, but sometimes you might want to modify that. And my experience is that ferrograd C tends to be better absorbed than Multifor. Is that just me, or?
Yeah, look, Multifor has quite a lot of marketing behind it and does market the less digestive system, so that they cause less constipation. I don't know if that's really true or not. I find that whatever iron they take, if you're going to get constipated, you'll get constipated. But Multifor is expensive. It's $27. Yeah, it's expensive. It's the most expensive one on the market. I like Ferrotab. It's got 60 milligrams of iron. It costs about $7.
About it.
Yeah.
That's fantastic. Yeah. Thank you, Vanessa.
Yeah. All right, so we might move on to platelets and pregnancy. Thrombocytopenia is the second most common hematological abnormality in pregnancy, with anemia being the most common. Thrombocytosis I won't focus on tonight. It's unusual in pregnancy. If you have a thrombocytosis, it's pathological, generally reactive to iron deficiency most of the time, although there can be some underlying myeloproliferative neoplasms that come in under that. So look, if they're not iron deficient, if they've got a thrombocytosis and they're not iron deficient, then refer on to see a hematologist. If they're iron deficient, just try and correct their iron first. And most of the time, thrombocytopenia is incidental finding on their routine FBE. And I like this graph that was printed in the New England Journal of Medicine in 2018. So as you can see, that compared to the non-pregnant state, which is the blue line, that throughout pregnancy from first trimester through to delivery, there is that left shift. So there is a natural drop in platelet count throughout gestation, and there's several reasons for that. One is that your plasma volume expands, you get a mild splenomegaly, and you have a placenta, and your spleen and your placenta sequester platelets, and they've got large sort of pools of blood that sit in there. So there is that physiological drop in platelets, and you'll see with where I put in the arrows, by the time at delivery, about 15 to 20% of women will have a platelet count less than 150. But even at the first trimester, up to 5 to 10% can have a slightly low platelet count. And if they're sitting low before pregnancy, and there's someone that sits normally at 150 or 160, they're going to drop in the first trimester to about 130. It's going to be normal for them. It's that sort of physiological drop in their platelets. When we look at thrombocytopenia in pregnancy, I like to think about them in two categories: pregnancy specific and non-pregnancy specific. And non-pregnancy specific is all the ones that you would usually consider. But when they're pregnant, we have a couple that we are particularly prudent about. One is gestational thrombocytopenia, which is by far the most commonest cause, 70 to 80%. Preeclampsia in the third trimester. And then you've got HELP and fatty liver. So they're the more pregnancy specific. Generally, all three are found present in the late or third trimester. But just to consider, there are non-pregnancy specific, and out of those, ITP would be the most common, around 1 to 4%, and everything else a much rarer cause, although we do look for them. I like this particular diagram, which breaks down the prevalence of thrombocytopenia based on trimester. of when you first notice the thrombocytopenia, as well as the degree of platelet count. So you'll see that in the first trimester, essentially the most common cause for a thrombocytopenia, if someone presents, say, with a platelet count less than 100, will be ITP, most 90% of the time. When you move across the second to the third trimester, the more pregnancy-specific causes become more prominent, particularly gestational thrombocytopenia. But when you get to more severe, a platelet count, say, less than 50, it's more likely that it's preeclampsia rather than gestational thrombocytopenia, which tends to sit up at a slightly higher platelet count. So it's important when you're thinking about thrombocytopenia in pregnancy is what gestation they are, how low is the platelet count, and where is it sitting, and when did it first start to drop. So what's my approach to thrombocytopenia in pregnancy? It's history. Have they been thrombocytopenic in the past? Is there a family history? Is there a history of bleeding? Is it real? So repeat the platelet count. Platelets are fluffy things that get clumped in tubes and so forth. So repeat it to check that it's real. Is it a new count? So looking at the prior counts. What stage of pregnancy? Is it on its own? Is it an isolated thrombocytopenia, or is there an associated anemia or neutropenia or something else going on that might suggest, hang on, there's something more of a bone marrow problem or something else happening? What's the lowest platelet count at any time in pregnancy, and is there any associated features? And those associated features are really mainly focusing on the third trimester. For example, if there's hypertension, neurological symptoms, deranged LFTs, renal failure, that point towards things like your fatty liver, your HELP, your preeclampsia, and so forth. What sort of investigations do we do? There's a lot of investigations that I request with thrombocytopenia, and again, it depends on the gestation. Essentially, I look at underlying coagulation studies, renal and liver function, antiphospholipid screen, and autoimmune screen, and viral serology is the most common test that I would request. When they present in the third trimester, we look at a preeclampsia screen, so looking at the LFTs, urinalysis as well. Then there's further tests depending on the history, and usually I would suggest just leave that up to the haematologist, and it's really just looking at the rarer potential causes of thrombocytopenia.
So Vanessa, you might have said this before, I might have missed it, but you know, in general practice, what often happens is you get the third trimester woman who gets the platelets at 125 and 130, and you're doing shared care with them. There's nothing to worry about, no symptoms, no other issues. In those cases, you're okay to just repeat it in a few weeks' time?
100%. So I repeat them every 4 weeks, 4 to 6 weeks. I get a lot of those referrals and really just provide reassurance to the midwives and the patients that, you know, would send the referrals through in the hospital. There's no data to show that in the literature, and I had a look at that last year to say, oh, look, 100, that should be your cutoff. If it's less than 120 or 130, when do you refer? There's no cutoff. But generally, if it's above 100, I'm not particularly worried unless there's other features. Yeah. All right, so I'd like to move on to a case I had a couple of years ago, actually. 25-year-old woman, G2P1, not unusual in our catchment at the Northern, who initially delivered overseas in Pakistan with an emergency C-section, had an epidural. She said, doctor, I had a low platelets at the time. You asked, well, how low they were? I don't remember. Or did you get a transfusion? She says, no. Were you treated? She says, no. So, oh, maybe it was just gestational. I don't really know. So we look into the history. You know, is there a family history? Is there a bleeding history? Is there anything that I need to know about? What's their surgical history? So have they got through any prior surgeries without sort of bleeding out and so forth, which would suggest that there's not a congenital, for example, thrombocytopenia. So you have a look at her booking bloods. She was microcytic at the time and anemic. She was actually B12 and iron deficient. And her platelets were good at 225. She has her next lot of routine bloods at 22 weeks. It starts to drop a little, 140. Yeah, that's probably okay. That would be consistent with a physiological drop. It's late second trimester. But then she came to me at 30 weeks with a platelet count of 83. And what do we do in this situation? You think, well, that's a significant drop in those 8 weeks. I repeat it. Is it real? Was it, platelet clumping or something else that's causing that platelet count? I did repeat it, platelet count 75. And so, okay, this is getting a little close for me. Is this gestational thrombocytopenia? Is this preeclampsia? Is this an ITP of pregnancy? So we request a film. First thing is to rule out a fragmentation hemolysis, so a HELP, TTP, severe preeclampsia. She has normal LFTs, negative hemolysis screen, so it's none of those sort of conditions. She has a normal blood pressure. Her urinalysis is normal. Her coags are normal. I repeat her viral serology and autoimmune screen in case she's, something's developed in that time, and all that is negative. So what is the diagnosis? I find these really hard when they get down to about 70 to 80 late in the third trimester, to really tease out whether this is gestational thrombocytopenia or ITP. And often I don't know until postpartum, and to see whether their platelet count responds or not, to know whether it really was gestational. I have my hunches and I have my suspicion, but sometimes you don't really know until then. And look, most commonly, it's going to be gestational thrombocytopenia. Unfortunately, but there's no diagnostic clue for either. They're both a diagnosis of exclusion. So we don't really have, I don't request platelet autoantibodies because they can be positive in normal patients as well. So they're not really something that we look at. There's some clues. Gestational thrombocytopenia tends to occur after 20 weeks. So a thrombocytopenia that's in the first trimester is most likely going to be ITP, not gestational. But when it's late in trimester, you can't tell the difference. With gestational, their platelet counts are normally normal. So I always look at their booking bloods and I try and find their pre-pregnancy bloods to see if they were normal outside of pregnancy. Generally, how low the platelet count can give you a clue. So most likely gestational thrombocytopenia platelet counts above 70. So if it's less than 70, it's more likely to be ITP. I do see, though, the rare, ones that are less than 80, and I do see quite a few that are about 0.1%. So we see about 4,000 births a year at Northern. So I would see the few that are gestational, and what I think could be ITP, and then their platelets respond after when I repeat them when they deliver. The issue with gestational and immune thrombocytopenia is that there's a risk of fetal thrombocytopenia in ITP to be aware of, but generally with gestational, fetal neonatal thrombocytopenia is rare. And I think if that does happen, the diagnosis was most likely ITP, not gestational. Both can occur in subsequent pregnancies, and they may or may not see an improvement on postpartum. But generally, most of the time, you repeat the platelet count 6 weeks postpartum, and it's normalised. And often I'll send patients back to the GP to do their 6-week FBE. So I actually have something documented for their next pregnancy that their platelet count normalised when they come back to me with thrombocytopenia again in pregnancy. So what's the principle of management? We want to reduce any bleeding complications with a severe thrombocytopenia. Generally involves a multidisciplinary team. And the monitoring of platelet count that we do really depends on how low the platelet count is and what the gestation is and what the cause is. So generally, if a platelet count is mild, sort of greater than 50 to 100, I would check it monthly in the first 2 trimesters until 28 weeks, fortnightly until 36 weeks, and then weekly after that. I don't like any surprises, and neither do the obstetricians. They don't want an antenatal, delivering with a platelet count that they weren't aware of or that dropped suddenly, and we weren't able to try and see what we could do about that. There's no evidence that a cesarean section is safer for mum or bubs in an uncomplicated vaginal delivery in women with significant thrombocytopenia. We don't suggest a C-section or vaginal delivery. So the mode of delivery is really determined by obstetric indications, and then we support the delivery around that. But we do need to consider that the neonate may be thrombocytopenic. So we do make some suggestions to the obstetricians about avoiding, say, high rotational forceps delivery, or avoiding a ventouse if possible, avoiding fetal scalp electrodes, and we make the suggestion, because at the end of the day, I'm not at the end there delivering baby, and I always advise the women that the obstetrician will deliver babies safely as possible. So when should you refer to haematology? And I guess that's sort of part of the question that Inez was sort of suggesting earlier on. Do I worry about 130, platelet count 130 in a third trimester? A platelet count less than 100 at any trimester, I would probably refer on to see haematology. We'd like to know about it and look into it a bit further. If you've had a thrombocytopenia outside of pregnancy, if they've got a known history of ITP, if there's a family history of thrombocytopenia, if they've got a history of bleeding, they've got other full blood count abnormalities, and particularly if they've got thrombocytopenia less than 20 weeks. And I get a lot of these, but repeat them, and we want to see it on several FBE reports. And I haven't put a cutoff there because there's no guidance on that, but usually I like it if a platelet count less than 120, 130 to refer on to haematology. How do we manage the thrombocytopenia? It depends on the cause. Essentially, with gestational, there's no therapy. If the platelet count remains above 70, 80, I provide a lot of counselling about whether an epidural is an option and what the options are prior to delivery. We can trial a bit of steroids, although anecdotally they say that steroids don't work in gestational. But I do give it a go just in case it might be a mild ITP. Sometimes we get some results, sometimes we don't. The differentiation between ITP and gestational is unclear, and that's not uncommon. I treat the pregnancy as an ITP. So I'll give a trial of steroids. I start at a lower dose, for example, may or may not consider IVIG, and I treat baby as if baby's an ITP patient with that potentially could have severe ITP. I won't go into second and third line agents other to say that we don't often need to use them, but generally that will be under the care of haematology should they need that sort of treatment.
Vanessa, how likely are both of them to recur in the next pregnancy?
So there's the recurrence risk can be up to about 10 to 20% for gestational. I find that most women will if they had gestational thrombocytopenia, will have it again. ITP is a bit hit and miss.
For GVP, it's quite common. That's what my experience is too.
Yeah. All right, we only have a few minutes really to cover thrombosis in pregnancy. And as primary care practitioners, I think you'd probably be very well versed in venous, in VTE. I'll just whip through this quickly and really sort of point out any salient points. Thrombosis is really the second most common cause of direct maternal death in Australia. So it is significant when it happens. It's important when it happens. So we do need to be vigilant in detecting in women. And the incidence is not insignificant. It's 1 to 2 per 1,000 pregnancies. So we see quite a lot of VTE throughout, say, the Northern and the Mersey. The risk of VTE is throughout pregnancy, so it's not just postpartum where the risk is much, much higher, as you can see from this graph. You'll see that there's a little bit of a spike in first trimester as well. So the incidence we see right across gestation, with the incidence increasing significantly postpartum. Why? With Virchow's triad, which is you need stasis, you need vascular damage, and you need a hypercoagulable state. All of those three are exaggerated in pregnancy, which is particularly why we see that increased rate during pregnancy. The signs and symptoms of a venous thromboembolism you will be well aware of. Just to be just conscious of the fact that with the PE, dyspnea, palpitations, feeling tired, a racing heart are all common in pregnancy. So it can be hard to tease out sometimes what's just pregnancy-related factors versus a potential PE. Just quickly on a case here, a woman presents with left leg swelling. What history would you like to know? Essentially, it's risk factors. And there are heaps of risk factors to look at, and I don't expect everyone to know that. Just to that there are a lot of risk factors. The main significant risk factors, if you can see right at the top, is previous venous thromboembolism. So that's the most significant risk. If ask them, have you had a prior clot before? And if they have, they most likely need to be on something for their pregnancy. That's the most significant risk. Then everything else kind of gets risk stratified as the major and minor risk factors. Thrombophilia is another one that often rears its head. You know, there's a family history, or they've got factor V Leiden, and so forth. And whether the key point here is that risk increases significantly when there's a family history and a thrombophilia. So just because someone's got a factor V Leiden doesn't necessarily mean they need to be on anticoagulation during pregnancy, or that they're at significant increased risk. It's really the family history with that increases that risk. So take-home messages are, is that a prior history of VTE is a significant risk factor, and a positive family history is the main risk factor. And then the third most common is people, women that are overweight.
And is that the case if they've got a factor V homozygous mutation as well?
Homozygous is different. Homozygous is considered a significant risk factor, and most of those that are homozygous would probably have had a VTE, and that's why they were diagnosed. And it's very rare to be a homozygote.
Yeah. But if you, I mean, because that's probably what we pick up in general practice too, is that, you know, factor V heterozygous or homozygous in pregnancy.
I haven't seen a homozygote patient.
Oh, have you?
No.
Homozygous in pregnancy, do we think we should refer them to?
100%. Yeah, that's considered significant. Antithrombin deficiency and anything homozygous. I do see the compound the compound heterozygotes. Yes, they. You know, you need to look at several risk factors, and I'll show you that in a second. I just will wisp through this. Look, diagnosis of DVT similar outside of pregnancy as in during pregnancy, other than if you've got a high clinical suspicion, you've got a baby that's covering all those big veins, and you can't do a Doppler in the abdomen. So if you've got a swollen leg and you've got a high clinical suspicion, we need to do an MRI really to rule out a DVT. Just some baseline testing before you look at starting anticoagulation therapy. Quickly, would you do a D-dimer or thrombophilia screen? Answer is no. It doesn't help for you. D-dimer is up most of the time during pregnancy. It may help you to rule it out, but it'll be positive 99% of the time. Would you do an inherited thrombophilia screen? Generally, I don't. I only do that if there's a really strong family history, if they've got recurrent VTE, or if there's an unusual site. And some of this testing is affected by pregnancy. So protein C, S, and antithrombin levels change during pregnancy. So I don't test them during pregnancy. I have to wait until they're not pregnant. I do test an acquired thrombophilia screen in all patients with a thrombosis. And by acquired, I mean antiphospholipids, antibodies, and lupus anticoagulant, because that can change the way we treat people. Imaging, VQ scan or CTPA is reasonable. Both of those, really it's whatever scan you can get. So generally, within hours, I would request a VQ scan, but after hours, it's generally a CTPA, because that's all we can get. The benefit of a scan far outweigh any risk to baby. So it's just about counselling and discussing that with women. What about treatment? What agent, what dosing, how long, you know, what about delivery? Does this affect my baby? They're all sort of the questions I get in practice. Warfarins contraindicated in pregnancy, and DOACs are contraindicated in pregnancy. Heparins are safe. We tend to use low molecular weight heparin. It's easier to give. They don't cross the placenta. They don't enter breast milk. So it's generally our go-to during pregnancy and postpartum if they're breastfeeding. If they're not breastfeeding, they can transition onto a DOAC postpartum. Therapeutic anticoagulation with low molecular weight heparin is what we recommend in all pregnant women. At a 1 milligram per kilo dosing, and the duration is a minimum of 3 to 6 months, generally throughout pregnancy though, and for 6 weeks postpartum.
Vanessa, we get a few queries from GPs when somebody's at high risk of a VTE because they've had one before, or and they haven't come into the hospital yet. Should GPs be starting their clexane at that point earlier in pregnancy? Because sometimes they don't get into the hospital, you know, at 16 or 18 weeks.
Yeah, that's a fair point. It's a difficult question, and I'll show you why when I show you the algorithm. Unless if you have an algorithm that you want to follow, the answer is probably yes. If you've got a really strong suspicion, I can only speak for the Northern. I get a separate referral pathway in terms of if your antenates had a VTE in the past, I'll get a separate haematology referral, and I see those patients within a week to 2 weeks, because I know they need to be on Clexane, or not, I can see from the referral, but not everywhere is the same. So,
and I mean, just with the GPs, we just suggested that they can generally send in their referrals after 12 weeks. So most of the testing, 12-week scans done. However, for high risk women, please send it in as early as possible and indicate such as that case.
Yeah. Any woman that's had a thrombosis in the past, I would put them on Clexane. The caveat is, no, if it's significantly provoked by a surgical risk factor, for example, then generally I look at other risk factors. But if you're worried about getting a patient that they're not going to see someone till 12, 16 weeks, call us, call the haematologist, or see if there's someone that you can call to get that advice, or call the haematology registrar at the hospital and say, I've got this patient, and what should we do?
And at the women's, people can always email me too, and I'll deal with it.
Yeah. So this is where you're getting at here, is this thromboprophylaxis in pregnancy, and it's really a minefield, because you need to look at thrombophilia, high risk, low risk, pre-pregnancy risk factors, and antenatal risk factors. There's a lot of things here to consider. And when you look at, this is the New Zealand guidelines, and you can look at the New Zealand guidelines, you can look at the Royal College of Obstetric guidelines, you can look at the American College guidelines. If you look at the American College guidelines, about 1% of antenates will be anticoagulated prophylactically. If you follow the RCOG guidelines, about 10% of women will get prophylactically anticoagulated. So there's a real spectrum of what people do. And as you can see here, that you really got to look at, do they have a major risk factor? Do they have minor risk factors? How many majors? How many minors? Suffice to say, if they've had a prior unprovoked or hormone provoked, they need prophylaxis. If they've had a provoked non-hormonal VTE, then you need to look at other risk factors. Do they have a thrombophilia? Are they overweight? Do they have a family history? And so forth. So, if there is a flowchart, you could use this flowchart, or if there's a flowchart you wanted to look at, then that's something you could follow to help guide you if you wish. When to refer. All women essentially should have a VT risk assessment at their first booking, if possible. We would suggest referral to haematology if they've been on anticoagulation prior to pregnancy. So if they're already on it for some other reason, like a mechanical valve or antiphospholipid syndrome or a recent VTE. If they've had a prior history of thrombosis, please refer on. If you're concerned about high-risk cases, or they've got multiple risk factors, if there's any doubt, or if you've got any new thrombosis in pregnancy, is when we would suggest a haematology review. At the Northern, we also do a postpartum VTE risk assessment as a mandatory component, and we do that within sort of 6 to 12 hours post delivery, because that risk of venous thrombosis is significantly higher postpartum. But as I mentioned, if in doubt, call your local haematologist or haematology registrar.
Or contact the GP liaison units. We can
there you go.
We'll facilitate some of that, which is great too. That was a fantastic talk, Vanessa. And just that last point that, I think that GPs are finding women more on postnatal Clexane as well, because of that routine assessment that's being undertaken at time of delivery now. We've answered lots of the questions along the way, which is great, and I'll collect some of those for afterwards. Just a little shout out from Joe Silver. I think that you said it already, Vanessa, but at Western Health, one of the routine antenatal tests is actually a hemoglobin electrophoresis. Obviously, if it hasn't been done before, that's not a routine test for women's unless the person's actually at risk.
Neither at the Mercy.
At the Mercy. No, I don't think it is at Mercy.
Yeah. No, it's only if you're at risk demographically, you've got low MCV or MCH. But the Western and the Northern, we have a different demographic. We have most of our patients come from a high risk areas, which is why we are both similar in terms of all antenatal tests. Yeah.
And hopefully, that'll be uploaded in my health record, so people might only have to have one during their life rather than every pregnancy, as it doesn't change.
Yeah.
That was fantastic talks. Thank you so much.
No
Vanessa.
problems.
And I'm just going to flick to my screen, if that's okay, just to finish off this evening. And it's testament to the fact that it's such a good talk that there's still about 200 people online. Let me just see if I can share. Could you, I can't seem to be able to share. Oh, here we go. I'll try that now. The current slide. That work? Yeah. So just thank you everyone for holding on. Just a few little wrap-up slides. 2 fantastic talks and 2 fantastic talks last week. So just a reminder about Health Pathways Melbourne. Hopefully people are using it. Written by GPs, free for GPs on your clinical software. It links to a whole lot of stuff, and we've got lots of things on pregnancy-related care, such as these areas here. Also, fantastically now, there's a little link where you can link your CPD hours as well, though you'll get an upload from these 2 sessions last week and this week because of your CPD. And they'll be actually personalised, the accounts soon. Also, just some health service updates. Shared Care workshop last week was fantastic also, and that recording, if it's not up soon, will be up. So hopefully you can watch the recording. If you didn't come to the evening, some things about Mercy, they're starting an advisory committee, and expression of interest is going out soon. They've got their primary care newsletter. Remember that they actually use, I think it's Health Links to send their referrals as well. Western Health is transitioning to Health Links shortly as another e-referral system, and there's some support there if you'd like it. I think increasingly GPs are, wanting e-referral, and it should work very nicely.
Sorry, Nez, it's not for e-referrals, it's for our outgoing messages. So referrals are still the good old-fashioned fax, but it's the secure messaging coming out from us. So all those things. Yeah.
And just everyone remember, one of the big things we have in the hospital is updating. Get your practice manager to always update everyone on the National Health Services Directory, new doctors and staff coming in, and the old ones that leave, or else you won't get reliable documentation. At the Royal Women's Hospital, we've got a public health fertility care webinar happening on the 24th of October. Please subscribe to our GP newsletter. The one in February this year, I wrote a little section on iron infusions and iron deficiency anemia and iron deficiency non-anemia, and talked about transfusions and oral supplementation. So have a look at that just to support lots of the things that Vanessa talked about today. We also did a session on psychotropic prescribing in the perinatal period and perinatal mental health that's online as well. And also there's some support for GPs that would like to train up and get support for providing medical termination of pregnancy as well. So that will come out to you in your paperwork. Attendance certificates will be received in the next 4 to 6 weeks. Check out the Northwestern Melbourne Primary Health website for lots of other CPD events. They do it very well and they support us magnificently. And that's it from me. So thank you everybody for coming this evening. Hopefully you've had your dinner already, or else you'll be running to have your dinner as I am. Enjoy and thank you. Bye.